Hey there, good evening. This is Dr. Sullivan. We are here with I Care for Your Brain. I am a board certified neuropsychologist, and I am here with you once a week to bring you really good quality brain health information and psychological empowerment. There's so many of you out there who are living with brain health challenges, and you're lucky if you get a little bit of good quality information, but typically not a whole lot of psychological information about how these things are affecting you. And that's really the thing that I am passionate about. So every week we get together and we share some nice time together on a Wednesday night, and I bring you a brain health lecture. I try very hard to make it as evidence-based as I can, and something that will be genuinely helpful. So tonight we're actually going to do something kind of fun. We're going to talk about brain health myths. These are the kind of things that really inspired me to want to put this program to you guys, for you guys together, because these are the kind of things that as a clinical neuropsychologist I hear over and over again in my practice. These are the kind of things that are just these urban legends about the brain, and they just will not die, but they're things that when people believe them, they can really reduce people's care, they can reduce people's hope, and they can keep people from seeing the very best brain health doctors to get them better. So that's what we're going to do tonight. We're going to talk about the top 5 brain health myths that drive me cuckoo. What especially bugs me is when these things are peddled for profit. They are often cited in the media as if they are fact. And when I go through some of these tonight, you're going to see these things are decades old, and we now know through advances in modern neuroscience that they are 100% not true. So we are going to get started tonight with the number 1 brain myth. And this isn't necessarily the number 1, like the biggest one. These are the top 5. You could basically put them in any order. So the first one is that we only use 10% of our brain. How many times have you heard this? I actually watched the movie Limitless a couple weeks ago, and that's basically the premise of the whole movie. This has Bradley Cooper in it and Robert De Niro, and basically the guy takes a stimulant drug that makes him have access to the 80 or 90% of his brain that he doesn't usually have access to. So he could reason amazingly well. He could make all sorts of memories that he couldn't before, and he shot up in the business world, and he's wheeling and dealing, and he was just a total superstar because he had access to this other huge part of his brain that he didn't usually. If you look back on where this all started, we actually think the first writing about it was in the 1929 World Almanac, and there was actually an advertisement in there that said there is no limit to what the human brain can accomplish. Scientists and psychologists tell us that we only use about 10% of our brain. And so you can imagine that the reason this is beneficial for why this is beneficial for marketers is that they then will give you products that will allow you so much more cognitive power, because they can have you access all of these different parts of your brain that you're not typically using. This is absolutely not true. We use virtually every single part of our brain all the time, even when we are sleeping. There is a neurologist named Barry Gordon, and he has put forth a couple different scientific papers refuting this myth. And so I wanted to share with you some of the things that he writes about. So he basically says, it's basically illogical, because we know from what we call functional brain scans, which is where when you look inside someone's brain and look at the structure of their brain, even if people are sleeping or they are meditating, we can actually see that glucose, which is one of the main fuels in the brain, is being used and uptaked all over in almost every single part of the brain. If we only use 10% of the brain, then a lot of brain injuries would result in no impairment. Unfortunately, there is almost no area of the brain that can be damaged and not result in some type of an impairment. Now, some impairments are more obvious, more measurable, more observable than others. And this is one of the big things as a neuropsychologist that I care about. And it bothers me that we have such an overemphasis on the physical in terms of brain health, right? If it's a physical issue, if we have some hemiparesis or, we have one eye that's not working, we can see that, we can measure that. That's very objective. But the cognitive issues, the emotional issues, the adjustment issues, these things are just as real. It's just that they're subjective and they're harder for doctors to necessarily see. And because we get such limited face-to-face time with most of our medical providers these days, those things basically get ignored, and it's up to us, it's up to you to go out there and to advocate for these things in that short amount of face-to-face time that you have with your doctor. Myth number 2 is that brain health is basically downhill once we hit middle age. There is a general idea, you've heard the sayings like you can't teach an old dog new tricks. Those things are so mean and they're totally scientifically inaccurate. As we get older, once we hit the age of about 65 or 70, we do slow down a little bit mentally. And you can actually look to the physical body for a parallel. We do get a little bit slower, gets a little bit harder for us to coordinate our walking, right? We're not quite as coordinated in our gait and getting to and from, we're a little bit slower. Very similar thing happens in the brain. And so we know that our processing speed just gets a little bit slower. The biggest thing that older adults complain about who are normally aging is a decline in rapid recall. We can also call this retrieval. This is when you know darn well exactly what that word is, what that actor's name is, what your acquaintance's name is, but you just don't have access to that information immediately. This typically happens because of white matter changes in the brain. White matter is basically the insulation on all of our brain cells and what connects brain networks together. And when that insulation degrades due to normal aging, when after years and years of having high blood pressure or too much cholesterol in our brain, these teeny tiny little blood vessels that help support the very inside of our brain that are on a big old circuit with our frontal lobes, they don't work as well. And we can have what we call white matter disease, also goes by the name small vessel disease, cerebrovascular disease. But basically, it's kind of like normal aging, pushed up a little bit. This is very frustrating for people. If you are someone who occasionally goes through that, you know that it can be very irritating. And part of that is that we don't have many coping skills when we are very young and healthy for this brain not working just flawlessly. It's almost like magic. The words, the names, they just pop in. When this process is slower and more laborious, my patients tell me it is incredibly frustrating. It's also true in my experience that the smarter you are, the more this kind of thing annoys you. And again, it comes down to coping skills. If your whole life you have been very intelligent, part of being intelligent is being a quick learner, a quick recaller. When that doesn't happen as effortlessly as it has your whole life, that is very, very, very frustrating. But I can assure you, the pause in your recall when you just cannot come up with a word feels the longest to you in your own perception. Many times people will tell me how much they're struggling to find a word, and I haven't even really noticed yet, and this is as a trained observer. So that's one of the critical things you have to know about normal aging is it will sometimes take you a little bit longer to come up with the information. We don't get worried when people have this minor delay in recall. We get much more worried if when given a reminder of something. So for example, if it is a recall problem, then really the issue should just simply be that you need a reminder or a cue to have that light bulb experience of the word, the person's name coming immediately to your mind. So for example, I had a patient in my office today who was saying that I have a really hard time if my wife just asks me, what did we have for dinner last night? So you can't come up with it. Well, that could be because you know the information, but you just can't find that file in your brain. That's a retrieval problem. Or it could be that you never really even made a memory of the whole dinner experience last night. So one of the ways we tease that apart in our testing as neuropsychologists is you give someone a little bit of a hint. If I say to them, well, was it salmon? Was it chicken? Was it spaghetti? Was it tofu? Was it, steak? If they immediately have that experience, oh, of course it was salmon. Well, there's our answer. That's a retrieval problem. If you give someone those same 5 choices and it doesn't ring a bell, it doesn't turn off that experience, that aha recognition moment, that is much more concerning. So that's one thing you can do with yourself, a loved one, husband, wife, is give them some options and see if, and you can tell by the reaction that someone has if it's like, oh, duh, of course, there's this recognition where it's just so accurate and it's just right there and they almost can't believe they couldn't come up with it before. If you get kind of like a, I'm not sure, that's a much more concerning reaction. And that's something that we see in dementias like Alzheimer's disease. And what that means is their brain is not able to make new memories. The new learning process is damaged and they are literally not taking in anything about new experiences. So when you go to give them the clue or the reminder, it doesn't really make a difference. So these mild changes in cognitive health as we get older, one of the key things I want you to know is that to be considered normal, it has to not be exerting a negative effect on your everyday life. And we've talked about this before, that there's 3 areas that I always want you to think about if you're worried about yourself or a loved one. And we call these instrumental activities of daily living. And to be diagnosed with dementia, you technically have to have cognitive issues that are new, right? You didn't have them before. And they are to the extent that you require supervision or assistance, support, help with these 3 things. The first one, and the most common area to see problems first, is complex finances. Around tax time, we get more referrals in my office because people are realizing, oh my gosh, this overwhelming amount of information, all of these files, all of these receipts, it's a lot of cognitive information to take in. Investment planning, Excel spreadsheets, all of these things have a lot of information. That's where you're going to see it first. The next one is probably with driving. And so this is because, especially in Alzheimer's disease, some of the very first changes happen in a part of the brain we call the temporal parietal occipital junction. That's a mouthful that basically tells us right around in this area here, we have some of the first brain cell death. And this is a part of the brain that helps us with direction, helps us remember how to get to and from where it is we're going and coming back from. If people get a little bit lost or disoriented in a new area, a new city, there's a lot going on, a lot of distraction, that doesn't worry us so much. It's more when it's in a familiar area, getting to and from the same store the person has been to for the last 10 years. And the third area is remembering to take medications accurately. This is a tough one to monitor, because the person who might be having short-term memory problems might not know enough to be able to say, I think I'm screwing up with my medication. So this is where that oversight can be a little sneaky and get someone a pill box and check it at the end of the day to see if there's still medications in there. But what I really want you to know about this myth is it's not only not true, but actually the opposite is true, that we actually get smarter in so many ways as we get older. We literally do get wiser, right? We learn from experience. This is one of the coolest things about being a human being is that you are able to take previous experiences, learn the lesson, and get better the next time it is presented to you. We increase our vocabulary as we get older, right? Just from being exposed to new information. Our social skills get a lot better. We get a lot better with resolving interpersonal conflict. And the research there suggests that we basically can read people quicker and kind of decide what type of conflict resolution is going to work here. Is this someone who needs me to be really assertive with the rules, or is this someone that maybe I'm not even going to bother with because no matter what I say, I'm not going to be able to change their mind anyway? What this really comes down to is our emotional intelligence. We get emotionally smarter as we get older. We get better at regulating our emotions, at finding more meaning in life. In some ways, some of the more important things in life, right? I would rather become more emotionally and personally smart as I get older in many ways than I would to get more book smart, right? Because this is part of the human experience, as we understand the interpersonal and how to support and get support from other people. Myth number 3, and this is maybe my most personally annoying one. which is that you cannot diagnose Alzheimer's disease until an autopsy. That is not true. Yes, back in the day, once upon a time, a diagnosis of Alzheimer's could only be confirmed at autopsy if someone had their brain looked at under a microscope and we were able to visualize the plaques and tangles that suffocate and strangle brain cells. Today, neuropsychologists can very accurately and very early diagnose Alzheimer's and all the other subtypes of dementia in at least 90% of people. I would say that's actually a lower estimate of what is realistic. There is not one Alzheimer's test. There's not one test that can diagnose dementia. It requires a comprehensive evaluation by an expert who understands aging and brain-related diseases. Specifically, I think a neuropsychologist. It involves detailed interviews, taking the time to actually talk to people and someone who knows them well. We usually have people come in for about an hour because of something I said earlier. It all depends on what is a change for the person. If someone was always very inattentive, they always had a hard time paying attention unless they were very interested in something, and they come in at 80 years old and tell me, yeah, that's exactly what's happening now, that's not really what I'm most concerned about. What we care about with the world of dementia is what is a change. And sometimes the person themselves is not in the best position to be the one to give us all that information. So we need someone who knows them well, and we compare and contrast what their reports are. We're very interested in exactly when things started to change, the rate of change. Is there anything that seems to make it worse? What seems to make it better? Is it all the time? Is it only when they're stressed, when they're sleepy? What's the medical history? Could there be a medication that's causing this? And then, of course, we do a lot of standardized paper and pencil testing, and we do this because we know how normal people at certain ages with certain amounts of education are supposed to do on these tests. And so we call this our normative data. And so we're able to say for a given 88-year-old woman with a bachelor's degree, how should she be doing on this test of verbal learning? And that's where we start to look at the pattern of her overall test battery, her performances, and say, you know what, this pattern here is concerning for normal aging. This is concerning for Alzheimer's disease. And it's really the integration of all of the test data that we use as neuropsychologists to make our determination about what exactly is happening in someone's brain. The subtype of dementia matters because it dictates the specific treatment. So what I mean by that is just diagnosing someone with dementia is really not good enough. And I want you to be able to go out there and advocate for that. It's an umbrella term, and we have 100, 150 different subtypes under that umbrella. Could be vascular dementia, Lewy body dementia, Alzheimer's disease. There's so many different things that people can have going on, and it's so very important, and people so deserve to have this early and accurate diagnosis. Not only does it help us make sense of what's happening to someone, what's changing, it's a way to explain to family and friends. There's community resources, there's medications that you want to be able to take as early as possible. We want to connect you to other people who are going through this so you don't have an additional issue of feeling socially isolated. We don't want additional issues like depression to creep in. There's just so many reasons. That's probably the reason I am a neuropsychologist, is because I believe so strongly in the early and accurate diagnosis. I see plenty of people getting diagnosed from these 2-minute cognitive screens in their primary care office, but I don't think that's sufficient. And there's a lot of data to suggest that they're getting it wrong when they're telling people you have a specific subtype. We think this looks like Alzheimer's. That is a big deal to diagnose someone with. And I think it is not respectful to say those diagnoses without getting someone through the gold standard evaluation for brain function, which is neuropsychology. Who can diagnose dementia? Well, I would say board certified neuropsychologists are your best partners. This is a service that is paid for by most insurance companies. You can get a referral from your primary care, your neurologist. We often have people message us and ask us, can you give me a referral close to home? We're happy to do that. There's also abpp.org where you can put in your zip code and they'll tell you of the closest board certified neuropsychologist. Myth number 4. is that the brain is hardwired. This is one of the most stubborn brain myths out there, and this is one that does people a lot of disservice. One of the biggest discoveries in neuroscience in the past few decades has been this idea of neuroplasticity. So we used to have the belief that you were born with a set amount of brain cells, and that was that. When they were dead, and nothing else happened in the brain. Well, we now know that through the process of neurogenesis, we make new brain cells all the way into old age. We have the ability to, every single time we're learning something new, we have to create new brain networks in order to put together the internal scaffolding, the ability to support doing that task. And so that is the motivation for new learning and brain stimulation, is that the fact that you're able to retain the new information and apply it shows that there has been some change in your actual brain architecture. There is a wonderful book called The Brain That Changes Itself. If any of you have read it, I want you to give me a little wave or a thumbs up here. We'll actually post the link on Amazon to it once I'm done speaking. One of the many things you will learn in this book that is utterly fascinating and full of hope is that people who were born blind have a different type of brain mapping in their occipital lobe. This is the vision part of the brain, and their visual part of the brain is actually devoted to hearing. So this is probably the most plastic part of the brain we think is actually our visual cortex. And probably it's because it takes up so much actual space in our brain. It's almost the entire back part of our brain. It's so easy to just think of vision as something that happens at the level of the eye, but of course there's so much. Probably the most complex thing our brain does is process the visual environment. If someone becomes blind during their lifetime throughout an accident or an illness or something like that, the visual part of the brain can then, through the process of neuroplasticity, reconfigure itself. Instead of getting input from the eye, it can actually learn to get input from the fingers so it can learn Braille more easy. If these things don't blow your mind, then I don't know what to tell you, because I can't think of anything more fascinating than that. It is very important to remember, though, that when we talk about neuroplasticity, this is not something that can happen after every brain injury or happen to anyone at any time. So we typically think the younger you are, the more plastic ability your brain has. We do know that even after the most serious brain events, there is absolutely a level of reorganization that can happen. But how much we can reorganize and how many new brain cells we can grow is very different for each person. But I get worried sometimes when we talk about neuroplasticity that we're sometimes giving false hope, because I think the truth is that unfortunately the brain can be permanently and catastrophically damaged, particularly if we have big areas of cell death or if we have bilateral brain injury. So what that means is if you have the same injury on both sides of your brain, that's a really hard one to recover from, because we basically have very similar structures in the left side and the right side of our brain, and we think part of that system of redundancy is that if one area gets damaged, we can basically switch it over, the function of that, to another part of the brain. So when you have bilateral damage, that actually gets really hard to recover from, because now there's really no new foundation to grow these new neural networks. Myth number 5 is that people are either right-brained or left-brained. This is one of those things that I hear all the time too. Oh, my husband, he's such a left-brained person. Well, there is some truth to that, but it's really not as simple as that. This stems from the popular idea that people are either dominated from their left hemisphere or their right hemisphere. And so the idea is right-brained people are more creative, they're more expressive, and left-brained people are more wordy, they're interested in vocabulary, they're more analytical. So while certain cognitive tasks do happen with more intensity on one side of the brain or the other, for example, language, speech production, for most of us that is in our left frontal temporal area, kind of right around here for most right-handed people. But for about 10% of left-handers, it's actually the opposite, and it's on the right side. And Typically, we think that that is from some early reorganization that had to happen in the context of maybe an early injury while someone was still in their mother's womb, or maybe during a birth injury. The brain, like I said, the younger it is, we think the more plastic it is. So yes, some of us are a little bit more verbal, some of us are a little bit more spatial, especially people who have certain kinds of learning disabilities. Verbal learning disabilities do tend to be more dysfunction, disorganization on the left side, and we have something called right hemisphere or nonverbal learning disabilities, which tend to be more on the right side. But it's really not as easy as someone is either a left brain person or right brain, unless of course you're missing one whole entire side of the brain, which is a thing that unfortunately happens. So I hope by having these discussions we can start to debunk some of these myths, get back to a more science-based approach to brain health. I think that some of these are really important to debunk, especially the hardwired one, and the idea that you can't really accurately diagnose Alzheimer's disease, because if we keep perpetuating them, that keeps people from trying really hard in rehab, that keeps people from having hope, that keeps people from advocating for a neuropsychological evaluation. These are three things that are very important to me and really fundamental beliefs that I have about the type of work that I try to do in the world. I believe very strongly in the power of neuropsychology to inform care and to result in personalized brain health recommendations. Also, of course, we really want to support people in having the very best recoveries that they can after stroke. This is exactly why we spent 2 years writing the Interactive Stroke Recovery Guide, because we didn't feel like there was enough good information out there about neuroplasticity and all the important things that you can do to promote more of these new brain cells being created in the brain, that process of neurogenesis. So if you guys like what we're doing over here, please share this video. The more people that can hear our science-based mission, the better. I'll be back with you next Wednesday at 6 o'clock, and I'm going to dedicate the next one to caregivers. We talked a little bit tonight about Alzheimer's, and as some of you know from my story, that is the brain health challenge that really got me into the neuropsychology arena. So I want to make sure that I am serving those folks in the very best way that I can. So if that's something that is important to you in your life right now, or maybe you've taken care of someone in the past, or you know someone who is trying to serve somebody who is living with Alzheimer's, please let them know about next week. Thank you guys so much, and I'll see you soon. Bye-bye.